Now we will have our Australian-Indonesian glaucoma. This time is glaucoma lecture series. Uh, we will have Dr. Yura, the resident from University of Indonesia, to present a case, and then will be followed by Dr. Jeff Cheng from Lions Eye Institute, right? Um, to to present about the management of difficult cataract surgery. So now we will have Dr. Yura to present the case. Please, Dr. Yura.
Yeah, thank you, Dr. Kirana. Good evening, Professor, Doctor, residents, and consultant. My name is Yura Pritama, and today I will be presenting some case from our hospital entitled Expecting the Unexpected with Navigating Zonolysis in Cataract Surgery. This will explore the intraoperative difficulties during cataract surgery related to glaucoma disease. So first, maybe we should talk about the connection about the glaucoma and zonulopathy itself. So glaucoma conditions of the eye could lead to zonulopathy, and this condition can happen vice versa. Chronic high IOP will lead to zonal stress, and as increased zonal stress will weaken zonal. So zonulopathy will lead to lens displacement, will lead to an undernarrowing angle, and IOP will increase. Zonulopathy itself will be found in 7.3% patients with PAC or primary angle closure. It was really highly related to pseudoexfoliation syndrome because due to its disease deposited the material. And intraoperative complication during this condition were found in a vitreous prolapse, capsular rupture, even an intraocular lens dislocation. So we proceed directly to the case. The male, 58 years old, came our clinic with a blurred vision and a high increase of IOP. So we found that visual acuity is 3.3/60 with an IOP 28 millimeter hydrogerum with thymol, tanopros, and brinzolamide. We also found the pupil is a little bit dilated with decreased light reflex, with the hazy lenses with found phacodenesis and a zonolysis in 12 to 4 o'clock hour. We found that the lens is placed anteriorly. So we assessed the patient with a secondary glaucoma with lens flexion of the left eye, and we plan to do the phacoemulsification plus insertion of IOL with CTR, CTS, or we do the ICCE with an anti-reflectome in a local anesthesia. So I proceed directly to the surgery video about this case. So at the first, we can see that when we using the making the main incision, we see when we insert the left push away from the zonal weakness from 12 to 4 o'clock hour. And we see even the features prolapsing from the main incision. So we and then this is when we identified the zonolysis and the lens. You can see there are space. So proceed to another moment when we are using the CCC. CCC was made. As we can see, when we do the maneuver for capsular access, there are movements in the lenses due to the zonal weaknesses. So we try to pull the traction counter to the zonal weakness area. So in this kind of condition, it's important to finish the CCC, not making it clear. So during this condition, we identified there are such instability in the capsular bag. So we just decided to directly insert the CTR. So the CTR was inserted because it was quite difficult because the lens itself still moving, the capsular bag is still moving, and we have not proceeded with the hydrodissection of the lens. After the CTR was inserted, we tried to do the hydrodissection, and we tried rotating the lenses. It was quite hard because the movements and the instability of the capsular bag itself. And we're using Tuschinski to try to rotate carefully to release the lenses. And in these sequences, we tried to do the phaco using phaco chop technique to try to minimize any lens rotation movements during the procedure. And after we're done doing the phacoemulsification, I try to fast forward. So in the IA, there are some signs that the posterior capsule kept moving towards, especially in the zonal weakness area due to its instability. As you can see from the video, we try to pull the remaining cortex. And we kept, as you can see, there's some reflex from the fundus. Try to be more directly pull it with tangential forces, not a radial tear, to avoid any capsular bag movements to finish the IA. And in these sequences, we can see there are some vitreous polyps from the back of the analysis. And we try to put it back with Visco and insert it manually. And then to the next sequence about the IOL insertion. So due to the capsular instability, even after we insert the CTR, so it is decided to do a partial Yamane procedure to the one of the haptics to help stabilize the lenses in the capsular bag. So the Yamane is only done in one of the haptic, not two of the haptics in the scleral fixation. This procedure was considered because it is too hard to insert TTS or capsular tension segment. Yeah, so because the zonolysis was too, from intraoperative, we see that the zonolysis is too, movement is too not stabilized. So it is decided to do a partial Yamane, and there's some manual anterior vitrectomy. As you can see, the lenses is in a centrally position. So to the next sequence, we injected myostatin, insert bubble, and do some sutures. And of course, the antibiotics, and the surgery was done. So let's move on to the discussion. We try to break down each of these steps that we see in the video, and we try to find any sources regarding the challenges and strategies in managing this kind of sequence in phacoemulsification. So CCC in zonolysis, we will find the challenges about the abnormal factor forces from the zonal weakness, which is difficult for us to maintain a stable and a controlled tear. And this condition will lead to increased risk of radial tears, of course, if not managed properly. Lens movement itself, if we found that the lens movement in these sequences, we should expect that there are some zonolysis or zonal weaknesses. So the strategies that we can do is to do a contraction while making the CCC. And of course, insert a viscoelastic to help counterbalance the outward forces from the imbalance of the capsule bag. A complete capsular axis itself is a must with a minimum 2 mm from anterior capsular rim. only difficulty that will be found in hydrodissection and rotation in zonolysis. You can see because of the instability, we will see there are some fluid path resistance, and of course, risk of capsular damage and incomplete transmobilization as we see from the video. So, the incomplete transmobilization is due to zonular weaknesses, which achieving a complete release of the lenses, it's quite difficult. And the strategy itself, we have to do capsular fornic hydrodissection to insert the cannula more deep in the capsular fornic and directing the fluid to it posteriorly. So it will prevent the fluid to reflux anteriorly and more controlled and effective hydrodissection. And of course, there are more safe techniques with bimanual techniques, and by using manipulation with the cannula. So in this case, we are using CTR as one of the device to make the capsule bag stabilized. So from theory, zonal weakness, if we found it below 4 o'clock hour, we will use capsular tensioning, not capsular hook. Or if it's more than 4 o'clock hour, we will use a capsular tension segment. So there are some timings to do the CTR, which we do in this video is an early insertion where after capsular access and before the lens extraction. Because it's during the procedure, we see that the capsular bag is so unstable. So it will help prevent further zonal dehiscence and maintain the integrity of the capsular bag. But the disadvantage using an early insertion is it can be complicate the cortical removal, which may the cortex be trapped between the CTR and the capsular bag. Late insertion itself it means we insert the CTR after the lens extraction, which allows us to easy removal of the nucleus and cortex without risk of trapping material. But again, delaying CTR, which will means the capsular bag will be unstable. So the CTS in this procedure, we did not proceed with CTS in procedure due to the intraoperative decision, which I will explain in the IL insertion section. And then we'll do the phakial modification in zonolysis. The techniques we were using is minimizing the stress on the zonule. So their technique chosen was phakial chop. Actually, there are more recommended technique with cross chop with a double horizontal chop to minimize the lens manipulation and reduce stress on zonal. And it is found is more efficient in nuclear fragmentation. And also there are some recommendations to do bimanual techniques to help stabilize the capsule during the phakial modification. The settings itself, it is preferred to using low settings with low bottle, low vacuum, low aspiration, and pulse mode is preferred in this kind of cases. In IA techniques, we are using the tangential stripping, so we are not making the radial forces during cortical aspiration, so we can minimize the stress on the zonals, which involves gently stripping the cortex in direction parallel to the capsular bed. And so the final one, maybe the crucial part will IO insertion and zonolysis. As you can see, because the capsular bed instability, we have risk of capsular tear and the orientation challenges when even we successfully insert the IO. So the strategy, we are using the CT or CTS, any sterile fixation. In this condition, we are using Yamane, even a partial Yamane, and of course, the choice of IO. So sterile fixation will be chosen if we see there is a zonular weakness. In this case, there are quite broad zonular weakness. So it is decided to make it a partial Yamane. And the choices of lenses itself, using a 3-piece of IO will be more advantageous and more flexible in the future repositioning or fixation if needed. So the conclusion, of course, the cataract surgery in glaucoma patient should be expected the zonolysis. And we should take cautious on every step during the CCC, hydrodissection, CTR, CTS usage, and minimum rotation on the vacuum technique, and assess capsular instability before the IL insertion. And of course, the most important thing, we have to educate the patients beforehand for any possible outcome with pre-existing conditions that the patient have. Thank you for your attention. This is the condition of patient, 1 month post-operative. Thankfully, they have a visual acuity of 6/9 with 13 IOP without meds. So I think with the planned procedure, we can have a good surgery result. Thank you.
Thank you, Dr. Yura. Very, very excellent presentation. Very nice case as well. Dr. Diala, do you have any comment about this? Is it your case?
Yeah, Dr. Firna, probably just summarize a bit. So actually, this case, we already prepare for the zonolysis. However, still intraoperatively, we have a lot of surprises during the surgery. So probably we will also hear the lecture from Dr. Geoff. Probably Dr. Geoff have some other comments and suggestion for this kind of case.
Yes.
Thank you, Dr. Fitna.
Thank you. Thank you. Very nice case. Dr. Yura, thank you very much for the presentation. And now we'll proceed with Dr. Jeff. Please, Dr. Jeff.
Amazing case, amazing case. And, really nice to see a whole bunch of, techniques in that video. In terms of the cataract surgery, really, I thought we just make it a fun kind of discussion, this evening. And so we thought we'd talk about kind of cataract surgery from the glaucoma surgeon's perspective. As Yura beautifully covered, what we do and when we anticipate zonulolysis, I thought I'd stick to some of the other kind of different scenarios that we may encounter. So, I mean, in terms of the learning outcomes, as ophthalmologists, we should all be kind of comfortable with the intraoperative management of these complex cataracts. And exactly as Yura and stated before, really, it's all about preparation and identifying or anticipating these challenges. So, as we saw before, there were numerous intraoperative difficulties and challenges faced. Where one must basically think about it beforehand or think on the fly about how somebody will actually manage those difficulties. So just taking one step back, I was actually thinking about this before the talk, but I realized that I'd actually done a lot of the cataract surgeries and before I actually sat down to figure out what was the origin of the word cataract. So I don't know how many of us have actually reflected on that. And it was actually a Greek patient that was in clinic with me who actually managed to kind of tell me this long-winded story about how the word cataract really comes from the Latin word cataracta, meaning waterfall. And so really it was about the description of the appearance of white kind of rapidly running water. And so in line with what we just discussed, this is one of the waterfalls in Iceland called Seljalandsfoss. And it's basically a gigantic waterfall. You can see how small the human beings are in relation to this waterfall. And it's a 60-meter drop. And so, that's me with the camera behind the waterfall. And it's really quite impressive. But the reason I bring that up in relation to cataract is really this is me on my trip to Iceland. And really, what you don't want to do is be the surgeon who is grossly underprepared wearing slippers, when everyone else is wearing big thick boots, right? So I guess the key to approaching any complex surgical case is really meticulous preoperative planning and preparation, as we saw from Adiela's case and yours. And absolutely, as Yura mentioned, as in the glaucoma clinic, we often deal with patients with often really tough cases. We see patients with PXF with small non-dilating pupils. Often there can be phacomorphic or angle closure related to synechiae and disorganized anterior segments. And of course, we're often the ones that will have to deal with, as you can see on the right photo, the hot cataracts where, due to lens-induced angle closure, you get corneal decompensation, a poor view, and often we're the ones having to deal with those tricky cataracts. And so really, it is frightening, but as you were said before, with the kind of very good patient education and setting patient expectations, we can deal with these situations. And so really, what I tell all the registrars is that cataract surgery is glaucoma surgery, and we know that. We know that when we do our cataract surgery, we often significantly improve the anterior chamber depth. We decompress these eyes, and we often open up the angle configurations. And with any cataract surgery, we know that we achieve a significant amount of intraocular pressure reduction. So those from the control group versus with cataract surgery alone, we know that we can get the pressures down significantly with cataract surgery. So cataract surgery, as for any ophthalmologist, it's really fundamental to what we do. And hot cataracts that we do, these are the angle closure eyes, and often there's the whole trifecta of these poorly dilating pupils, these really, really shallow angles. And often they're very, you can get a lot of pigment on the corneal endothelium, making view difficult. And with this patient who had an anterior chamber depth, this was probably the lowest ACD that I've ever done, which was 0.53 millimeters. Sometimes we have to do vitreous decompression, as this case required, just to actually create some space in that anterior chamber. And so these eyes are tricky surgeries. There's always the risk of aqueous misdirection, which we can worsen from our surgery. We've already discussed vitreous decompression or vitreous prolapse, as Yura mentioned. Often there's no view, poor zonular support, and often we're dealing with atonic pupils with degenerate capsules. So really tricky kind of situations. And so the only thing I'd say about angle closure cataract surgery, prepare yourself, as we mentioned before. I always give a drop of atropine to rotate the ciliary body backwards. Preoperative mannitol is a godsend, and we'll talk about that. You can consider using a high viscosity ophthalmic viscodispersive, and Helon GV is really good for that task. Often when we're doing the rhexis in these eyes, the anterior chamber is very shallow. So, refilling the anterior chamber and reforming the AC depth as necessary throughout is really useful. And as Yura said, playing around with the bottle height or the infusion pressure in these cases can be very useful. So Yura's already shown what we happen, how we deal with zonulolysis. And so really, my tip there is that, identifying the zonulolysis early, either preoperatively or intraoperatively is important. And here, often with these anticipated cataract challenges, I'll actually use something really sharp. And so I'll play that again. Here, I actually use one of my side ports to actually initiate the capsular rhexis. And here, you're actually seeing wrinkling of the capsular bag. And if you're seeing the capsular bag wrinkle like this, with a difficult initiation, you know that there's a significant amount of zonular laxity there. And so, that's a still. And really, you're looking for those star folds, on that capsular bag. And here, you know that there's going to be zonular lysis. This is a post-angle closure cataract. After we successfully get the lens out, we know that the zonular bag should not be flopping around like this, as Yura mentioned. So really, these are eyes at high risk of complications. And so here you're watching the bag flop around, and where there's less than 5 clock hours of zonular instability, really just filling up the eye and putting a standard capsular tension ring can be suffice. Often if there's 6 to 7 clock hours, then we're really talking about suturing a capsular tension segment in. So as a standard, we use the Ahmed segments. But I often find that injecting, or as Yura showed you, kind of rotating a capsular tension segment can really help to support that bag. So the other thing that can be useful in these situations are capsular support hooks. So these are the McCool hooks. And where you've got lots of zonular instability, you can basically place these. Typically, I place them 2 millimeters from the limbus, and you can actually use them to support and encapsulate your capsule or capture the edge of your capsular rhexis to just give that counter traction for when you're completing your rhexis or performing phaco. I thought I'd touch on capsular phimosis syndrome. And in these zonular lytic eyes, what you typically see is, because the zonule is quite weak, you'll see shrinking of the capsular rhexis after the cataract surgery. This can happen quite quickly, and often it's asymptomatic, but significant capsular phimosis can lead to IOL decentration or even dislocation. And if the capsular phimosis actually shrinks down to involve the visual axis, patients can be affected. So it's really something to look out for in these patients with kind of generalized zonular laxity. And the risk factors here are any cause of a small diameter capsular rhexis, PXF, or other causes of zonular laxity, which you can also see in high myopes. So this can be treated. What we can do is an ND-YAG laser capsulotomy, where we make radial nicks across the anterior face of that capsule. And that can actually relax the capsule and stop the progressive contraction. Just a touch about mannitol, that pretty much goes in all our patients with previous angle closure, and standard doses are 1.5 to 2 grams per kilo. It's typically administered as an intravenous infusion, and over a 60-minute time period with effects up to 6 hours. And really, if you look at the studies of mannitol, what it does is dehydrate the vitreous. And here's actually a radiology-led study, which actually shows the reduction of globe volume, predominantly from the vitreous cavity after you infuse mannitol, whereas that actually increases the orbital volume. And so it actually draws fluid, away from inside the eye. And that can help our patients. The effect of mannitol doesn't only dehydrate the vitreous, but of course we use it in angle closure to actually lower the intraocular pressure of our patients. And the side effects of mannitol must be known. So just as a refresher, really you can worsen dehydration, and it will cause diuresis. So these patients will often have to go to the toilet. And the fact that it draws fluid into the extracellular space means that it can precipitate things like heart failure or pulmonary edema. And so you have to be careful about these patients. It can certainly worsen electrolyte abnormalities, predominantly with hyponatremia and hyperkalemia. And it will worsen cerebral edema. So there have been reports of death after mannitol as well. So basically don't take it lightly. Moving on from angle closure type eyes, here's another case of intraoperative shallow anterior chamber, and here's a surgeon who's doing the hydrodissection. You can see that they're burping viscoelastic, but it's quite a copious injection there, and you can see that as they're injecting, basically the AC shallows and iris starts prolapsing out, and so where the AC becomes fat and flat and the eye becomes really high with high intraocular pressure, you've really got to think about a few different things. And here, intraoperative gonioscopy can show rotation of the ciliary body processes. And if you actually anterior segment OCT these patients, there's a forward rotation of that ciliary body. And so just to cover what's happening there, this is really not post-operative aqueous misdirection, but intraoperative aqueous misdirection. And so here, what happens is that fluid actually goes behind the lens and actually prolapses the entire complex forward. Typically you'll see intraoperatively, you'll see shallow AC develop, as well as positive vitreous pressure. And really what you can do is reduce the vitreous pressure. Typically you'll release the speculum. If you don't have access to a vitrectomy, you can actually just stitch the eye up and just, let the eye try to balance out. Or intraoperatively, what you can do is you can either wait for things to settle down, or my preferred method is a pars plana tap in these individuals, where you can actually just break that fluid interface. And so here's a video of what's actually happening in these situations. Typically, you'll have the vitreous face behind the lens. And here you've actually got the arrows pointing to what's known as Weger's ligament. And so Weaker's ligament should actually stick the vitreous face onto the back of the lens. What happens in some patients is that that ligament actually weakens and dissolves over time. So here you'll see that the anterior vitreous face actually comes off the lens. And what can happen is that after you're doing your cataract surgery with any infusion, especially if there's any zonular weakness there, the fluid from the irrigation can actually start to infuse, and it can actually start to cause that lens to actually prolapse forward, as we can see in the video here. So what you're actually doing is you're actually hydrating Burgess space. And so as Yura showed you, when the eye starts coming forwards and the lens actually starts coming towards you, there's a really high risk of posterior capsular rupture, because basically the posterior bag is actually coming towards your instrument. So here's intraoperative OCT in the next case. Oh, here's the Burgess, Dr. Emil Burgess, anatomic description of Burgess space, which is basically a potential space that sits behind the lens in the anterior hyaloid. And here we there's no video here, but basically there should have been an intraoperative OCT showing the potential space. So and here's OCT showing that Burgess space, or that gap between the back of the lens and the anterior hyaloid. And here's that intraoperative OCT. Here we're actually zooming down, and you can actually see that there's actually a whole bunch of debris and dirt. And you think that that's in the vitreous, but in actual fact, the IOCT actually shows that that's actually kind of remnants from the cataract surgery and from the lens that's actually sitting behind the capsular bag there. Yeah. So once again, in these intraoperative aqueous misdirection, what you're doing is you're hydrating this potential space. And so, here's a case of intraoperative aqueous misdirection. You can see the iris prolapse, the very flat anterior chamber with the, here it's actually happened at the end of the surgery. And so a subtenon's anesthetic is done. The eye is rock hard here, and you can see that the cornea is actually starting to haze up. So, what we'd typically do is a limited perotomy. And basically, with an MVR stab, you can use your, vitrector. The other option is actually doing a vitreous tap. But here you can actually see the vitrector foot down, and you can actually see that vitrector going through the pars plana, reaching out underneath that intraocular lens. And what you're doing is you're actually just breaking up that anterior hyaloid so that the fluid can equalize with the vitreous. So here's my foot's down. You can see the vitreous cutter behind the intraocular lens. And, it's a safe technique. The vitreous is going on, and immediately you can see that when I push on the globe, the eye's soft, the AC is reforming here. And so, now the rest of the cataract surgery can go on, and, basically IA can be done at this point. The other thing to think about during your surgery is, in a complicated surgery, here's a surgeon trying to, hydrate one of the wounds. And the other thing when the eye becomes very firm is, the dreaded suprachoroidal hemorrhage. So what you'll typically see there is a choroidal hemorrhage expanding across the eye. And if you ever see that sign, it's time to really get out as soon as you can before a potential expulsive hemorrhage can happen. And we spoke a bit about iris prolapse earlier on, and I guess sometimes you just can't help it. So here's a patient with an incredibly high hyperemetropic script. Here's his biometry, and here his axial length is around 20 millimeters, and so that's significantly short. That goes hand in hand with a reduced anterior chamber depth. And so we can see here that it's a 35 diopter, 35.5 diopter lens needed to implant inside these eyes. And so if you see an eye this small with glasses that thick, really you're dealing with an ophthalmic eye. And so just as a refresher here, we've got A, B, C, and D. A is a normal eye, and B actually shows a microphthalmic eye, which can be either simple or complex, depending on if there are any other ocular abnormalities associated. And just remembering that nanophthalmos means the eye's both short at the anterior segment of the eye. So it's a small eye anteriorly, and it's a small eye posteriorly as well, with a small axial length. And so there's different cutoffs in the literature, and most people will say that an eye less than 20.5 millimeters will qualify as a small eye, with a globe measuring less than 20 millimeters or 21 millimeters representing an axial length shorter than 2 standard deviation values. And so these eyes have typically very thick sclera, and so you can see that that can be an additional diagnostic criteria. And so talking about these, angle closure eyes, here's a patient with nanophthalmos, the patient that you saw before, actually, and he'd had previous acute primary angle closure, dense cataract here. And here you can see that it's an incredibly shallow anterior chamber depth we're dealing with. We're making a side port here into the eye, very flat. And, just so we can do our main blade, we're trying to inject some OVD, but here you can see that the atonic iris is already wanting to prolapse towards even the side port. With that vision blue, and after you wash out that vision blue, you can see that that iris is already wanting to prolapse once again. You can see it's a very floppy iris at this point. So basically a dispersive viscoelastic can be used to try and push that iris away. But these are realistically very tricky and difficult cases to do. You're trying to form the anterior chamber to create some space for yourself, but even through a side port before the main wound is done, you can see that the tendency for that iris to prolapse is real. Yeah. So here we're making our main incision, and here you can already see that the iris is trying to prolapse from every single wound imaginable. So in these cases, 6-gauge needle is useful, and often in these cases, there won't be enough space to reliably put a Malugin ring or an eye ring. And so really, iris hooks are the way to go here. And here you see an iris hook by the side of the main blade or the main wound, just dialed into a position so that the iris can actually be pinned and dragged away from that main wound, so that capsulorhexis and the rest of the surgery can be performed. But once again, here we're aiming to do a relatively large capsulorhexis, but one can see that it's a really tricky scenario where there's really a lot. Here we're refilling the anterior chamber depth once again as much as possible, and just reliably trying to reform everything so that the capsulorhexis can be completed. And so, once again, the problem with these eyes is that they're hypermature cataracts, they're small eyes, there's not much space in these eyes. And so really they're kind of tricky eyes to deal with. And here you can see that with that zonular lysis, the cataract or the capsules don't often end up round at the end of the case. And so, cataract surgery in the small eye, it's a whole topic unto itself. These short eyes are surgically challenging with a high risk of intra and post-operative complications. We always worry about corneal decompensation. Uveal effusions are the big post-operative complication to look out for, with case series showing up to 50% of these eyes can get uveal effusions, aqueous misdirection, cystoid edema, and of course, vitreous and suprachoroidal hemorrhage. These eyes are technically more challenging to operate on because they're small eyes deep within these, often, small orbits. And often the pupil dilation is a lot poorer. And so, here's another lady that was referred for, cataract surgery. Here she's got, plus 15 diopters of hypermetropia. And here you can see that axial length is actually 16.5 millimeters with an anterior chamber depth of 1.75 millimeters. And what's good to do in these situations is actually, formally documenting the scleral thickness. And so here you can see scleral thickness measurements at 2.4 millimeters. And around the posterior pole, normal scleral thickness should be around 1 millimeter. So she's got an incredibly thick sclera. And so, if you ever see those kind of measurements, you really should be, prepared. Uveal effusions are what these patients get, and that's because there's often, protein accumulation in the subretinal space, and these eyes have thick choroid where the vortex veins can't actually flow in and perform so well. And so, look, in these eyes, we typically create preoperative scleral windows. What you can actually do is you can actually do a 4 by 4 millimeter, essentially almost similar to a trabeculectomy flap. And you can then excise a 2 by 2 millimeter block from these eyes, which basically allows the uveal fluid to seep out of the eye safely. And that's well described with numerous randomized control trials showing that complication rates are significantly reduced after prophylactic sclerostomy. In this case series, it was actually done combined at the time of cataract surgery. And in these eyes, you can see that the sclerostomy group pretty much brings the choroidal effusion rates down to 0, whereas in the control groups without sclerostomies, there's significant choroidal effusion rates. And so, cataract surgery in these non-ophthalmic eyes are associated with a high risk for vision-threatening complications, but performing a simultaneous prophylactic sclerostomy can significantly reduce the complication rates. And just as another fun case to end off, the kind of glaucoma, angle closure kind of cataracts. This is a gentleman that was referred to our clinic. He's a 59-year-old gentleman with previous bilateral implantable Collamer lens implants. And so these are ICL lenses that are designed to sit in the sulcus on top of the patient's natural lens. And it's performed as a primary refractive procedure, typically in high myopes like this gentleman was. You can see that here, the previous surgeon 11 years ago had put in, peripheral iridotomies as should be done for the original designs of these ICL lenses. But this is a patient that was, -6 diopters prior to the ICL. He did have a history of right amblyopia with no family history of glaucoma. And the reason he was actually sent was because he actually started noticing a scotoma in his vision. And so what wasn't picked up was that he'd had actually significant glaucoma related to both the underlying myopia as well as the pressure rise related to his ICL implants. So here you can see significant thinning, especially of the inferior neuroretinal rim. Similar picture in the right eye with diffuse losses. And his visual field showed significant scotomas related to, the areas of optic nerve degeneration. So here the patient actually presented, remember his right eye is the amblyopic eye with a vision of 660, his left eye was 612, pressures of 25 in a highly myopic eye. And so really a diagnosis of secondary glaucoma was made. Gonioscopy showed that there was a significant Fuji sign, and here you can see a volcano iris configuration. And this patient had essentially closed angles with a lot of pigment within the angles on gonioscopy. You can see that superior angles are closed there with, once again, pigment blotching. And so really there's a secondary pigment dispersion as well as a secondary angle closure that's happened here. And so just as a reminder for anyone who implants ICL lenses, most studies show that between baseline, so this is before surgery in the column on the left, and 1 month after surgery, you get about a 40% narrowing of the anterior angle configuration with an ICL implant in the sulcus. And here at 3 months, you can see that that trabecular iris angle essentially stays the same from that point forwards. But, in this patient, he basically developed pseudophacomorphic glaucoma-related angle closure. And here you can see that on the pentacam, you can see a really high lens vault. And here you can actually see the ICL pushing that iris forward, causing that secondary pigment dispersion and causing that secondary angle closure. So in this instance, the patient actually had a oversized ICL, so an ICL that was too big for the patient's eye, and that was what was causing the high lens vault. And so, in these cases, you really want to make sure that the patient does have a patent peripheral iridotomy, because especially in the older designs, without one, these patients will present with angle closure. But realistically, the problem is oversizing, which can lead to excessive anterior vaulting. And so, basically the size of the ICL can be predicted much better now based on white to white. So we don't tend to see this as often now. Implantable Collamer lenses have their own complications, with pupillary block and shallow AC being numerous ones of them. And here's that patient that we saw from before. Once again, you can tell that it's a really shallow AC at this point. And so his pupil actually didn't open up. So here there are iris hooks going in. Once again, iris hooks are used because there's no space in the AC. And here we're actually having to bring the ICL that's causing the high lens vault into the anterior chamber. Here you can actually see that, we're refilling and using numerous amounts of viscoelastic to protect the cornea, especially when the angles are closed and the AC is incredibly narrow. And realistically, if you've got the right Fetchner forceps, you can pull the ICL out as a whole. But otherwise, you can then, essentially proceed with cataract surgery as per normal. Here you can see that, once again, there is some mild zonular laxity here, but, the rest of the case goes smoothly. And so here's basically an example of an ICL explant, prior to cataract surgery with angle closure. But, basically this patient does well. Here we're being a bit cheeky. The patient has a pretty good pressure with, eye drops alone. But here we're taking the opportunity in theater to actually have a look at the angle here and do some intraoperative gonionoscopy where we see those pigmented angles and the iris leading up to it. So here we're just sneaking in little, eye stents for whatever it's worth since we're doing the surgery. And here we can see that it's a very pigmented angle. And, that's the end of the case with blood reflux from the trabecular meshwork where the eye stents are placed. So, this patient does well. And you can see that here before the surgery there compared to after the surgery, the angles are significantly wider. And so, look, there's a whole bunch of intraoperative challenges. I think Yura and Adiel have presented just that beautiful case of that really tricky cataract surgery with zonulolysis. But really, as cataract surgeons, we should all be ready for anything that can come up on the table. And so, really, there's a lot to talk about. But that was just a few interesting cataract cases from a glaucoma surgeon's perspective. But, really the takeaway messages for all of us are, to plan more. So before you get the patient on the table, you really want to identify any risk factors. You want to do that preoperative planning. And so, where that patient's got zonulolysis, you're thinking, do I need to order a three-piece lens for a potential Yamane, prior to surgery? Cataract surgery in eyes with angle closure is challenging. And really, you should be looking hard during the surgery and before the surgery for impending signs of doom. And once again, we all make mistakes and we're all human, but we should learn from every case. And this is just a quick plug because Dr. Jonathan NG and I are, in charge of organizing ANSGS, and we have the great pleasure of hosting in Perth next year. So that's early in February next year. So it'd be great if I think Professor Werner's kindly agreed to join, and it'd be fantastic if everyone here had the time to join. You guys are most welcome. Lovely, thanks.
Thank you, Dr. Jeff, for excellent presentation. Very, very insightful. Thank you so much. And then now we will proceed with the discussion. There is no question yet. Okay, so is it quite often with the I think angle closure with the cataract problem? Is it quite often in your country? In Australia as well? Or
I think Bill could speak to that. I think certainly it'd be less common than in Indonesia, where there's a lot of I understand a lot of really dense cataracts that present late. So I imagine there'd be a lot of phacomorphic angle closure that presents to the clinics. We certainly get it from time to time, every few weeks or so. There'll be a lot of, phacomorphic angle closures that are typically managed with peripheral iridotomies in the emergency setting. And then we'll be referred to our clinics for, subsequent cataract surgery or further management should the pressures not come down.
Okay. There is a question now from Dr. Regina. Thank you, Dr. Jeffrey, for your interesting presentation. I'd like to ask, in what case we be watchful in phakic IOL case regarding the development of secondary glaucoma?
Yeah, so look, I think it's interesting, and certainly I actually spoke with the corneal surgeons who tend to implant these ICL lenses. So really the answer is in all cases, one should be counseling these patients about the risk of secondary glaucoma, because there's about a 5 to 10% risk even with the ICL implants. There's a newer generation with what's called an aquaport within these ICL designs. But certainly gonioscopy is very useful after the phakic IOL implant. And I think the other thing to be mindful of is even if you're not going to see these patients, they need to be seeing some kind of eye specialist for a review, every year or on an annual basis. So really, it's not an implant and forget for these patients. Subsequent to the surgery, they often develop, either anterior subcapsular cataracts or, can develop other complications. Certainly, if there's going to be pressure rise, then, one, of course, should be mindful of the, secondary glaucoma. If it's going to be an acute pupillary block related to the phakic IOL, that will present within the first 48 hours of implantation.
Yes, yes. Thank you. And now the other question from Dr. Vidya Anandita. In patients with intraoperative malignant glaucoma that happen before insertion of IOL, do you have any tips on doing safe vitreous step to avoid PCR? Thank you.
Yeah, so look, so it really depends on your access to a vitrector and kind of your own kind of personal experience. So you can do a dry vitreous tap that is well described. Typically you'd use a 3 ml syringe with a 26 gauge needle on the end of it. And really what you want to do is you want to go through the pars plana. I typically go at 4 millimeters from the limbus, or 3.5 to 4 is your safe zone, as you would for vitrectomy or your intravitreal injections. And where you say avoiding PCR, if you basically put your foot down on the vitrector, you want a relatively low cut rate. After your initial high of about 4,000 cut rate. But as long as you're directing your tracker pointing towards the optic nerve, that will be a safe thing. And the other thing that you'll do is you'll be able to see your vitrector behind the intraocular lens. Or behind your phakic lens as well. So you should be able to see it most of the time. And that way, as long as you've got the angle of insertion correct, you should avoid actually capturing the posterior capsule with your vitrector there. And just as a comment on that, if you do have intraoperative aqueous misdirection, some people actually talk about doing an iridozonular hyalodectomy. So, or actually going through the posterior capsule with the vitrector itself. But my preferred technique is actually accessing it from the posterior segment. So what I mean is in some instances, you might want to create a PCR.
Okay, thank you. Yeah. Sometimes I often also like taking the aqueous from the posterior chamber. When we know that there is aqueous actually entrapped in the vitreous, sometimes we could do like vitreous stepping, right?
Yep.
And after,
Absolutely.
yeah.
Yeah. So that's the dry vitreous tap that I was doing. Yeah. So if you don't have access to a vitrector or you don't want to open the vitrector pack, then a dry vitreous tap, especially for an older patient who has vitreous syneresis, is okay. But often with the vitrector, you know that there's not going to be any vitreous traction, so it'll minimize your risk of pulling on vitreous that's attached to retina.
Yeah. Now there is also the question from Dr. Hamdan. I think I would thank you for the presentation. I would like to ask about the timing for the use of CTR. When we found instability of the capsule or zonolysis, when should we use CTR or convert to ECCE or ICCE? Does it only depend on how much clockwise from zonolysis, or are there other considerations? Is the selection different in patients with cataract and glaucoma?
Would Yura and Ardiela like to speak to that, or Professor Werner?
Dr. Diela want to talk, Dr. Diela, please, about the CTR?
Okay, I think Dr. Yura also already stated on the slide here. CTR can use if the zonolysis is less than 180 degrees. But other than that, also probably the consideration also about the timing, whether we should insert the CTR early or later on. So I think, yeah, for the CTR especially, we can use for the zonolysis less than 180. If it's more than 180, then we cannot use CTR. Probably we have to use other like CTS also. Yeah, and probably can edit Dr. Jeff if you have any other comment.
Yeah, no, absolutely. I think Yura and yourself summarized it really well. The catchphrase we use when it comes to capsular tension rings is you want to use it as late as possible, but as early as you need. As late as possible during the surgery, but as early as you need. So in that case, you can see that in Yura's case, you can see that the CTR was actually placed very early on in the case when the whole lens was still in the bag. And so that certainly helped to stabilize the zonular lysis. The issue being that with the capsular tension ring inside the eye, it really makes lens removal, especially of the cortical aspects, difficult, because what happens is that the ring will actually trap the residual cortex that's adherent to the side of the bag. So but once again, where you have a lot of unstable bag, you might need to use it and just accept that that's going to be the case. As Ardiela mentioned, you can only use CTR when there's less than 5 clock hours. So realistically, if there's up to 3 clock hours of zonular to do anything, what you need to do is you can actually implant your intraocular lens, and you should aim to put the haptics up against the area of weakness. So the actual intraocular lens itself and the haptics can actually stabilize the bag in that way. Where you've got less than 4 clock hours, then a CTR is indicated. In terms of your second question, the CTR does not differ in patients with cataract and glaucoma. The only proviso there being in small or non-ophthalmic eyes. I know Professor Morgan's dealt with a case where a lady had bilateral angle closure from a capsular tension ring being put in an eye that's very small, which then caused a secondary pupil block or a secondary angle closure. The capsular tension ring from Morcha actually comes in 3 different sizes. And so the size of the capsular tension ring should actually be selected based on the white to white of the patient's eye. So just to be aware that there are different sizes. 14C would be your standard size, but there are different ones available.
Morgan, do you want to comment about this?
Yeah, no, I agree with what everyone said. Jeff's referred to a case where patient had cataract surgery. She had a short eye, I think it was about 20 millimeters, and had capsule tension rings put in just as a routine because she had a Zeiss, which has large haptics, to reduce the rotation of the lens by a refractive surgeon. The trouble with the capsule tension ring is that if the patient's got ciliary block, then you don't, or tendency to malignant glaucoma, you don't really want to use capsule tension rings if you can avoid it, because they tend to keep the capsule more expanded out towards the ciliary processes and can maintain ciliary resistance and ciliary block. But the thing is, if you have to use it, you have to use it in order to support the zonules. Used to use capsule tension rings in every patient with pseudoexfoliation years ago, but I'm not sure if I became a better surgeon. I don't know what happened, but I found it's such a nuisance when you got to the part of having to try and aspirate the lens cortex with the trapped lens cortex. So I gradually over the years, I've avoided using them where I can. But that case that Una presented, I mean, obviously, you're never going to remove the lens without using capsule tension ring. I'm amazed you're able to do what you did, actually. I've seen you do. Many of you operate on really tricky cataracts that I have to say I haven't seen we don't get those sort of cataracts, actually. It's kind of a bit like coming to a zoo. When I go to the operating theatre in Indonesia, I see stuff that I haven't seen for a long time. I know, Verna, you had a really difficult case recently, last year when I was there, with the Osmaya. I remember seeing that. I was thinking, I'm so glad you're doing that case and not me. So I'm not really answering your question very well. I think understanding the physiology and the physics is really important, and the size of the patient. And I think Jeff mentioned this, when you see a patient who's got a small eye, then you really want to think about all the steps in the cataract surgery that can go wrong and where they'll go wrong and what you're going to do before you get into the surgery. So you have a good plan. I don't think I can add much more, Berna. Thank you.
Yeah, thank you, Prof. Now maybe there is two question again to Dr. Chan. What do you think about it? Is from Dr. Felicia. What do you think about phacotrabeculectomy procedure? Do you prefer to do it separate, or in what case we should consider to do them simultaneously? Please, Dr. Chan.
Yeah, so I guess that's a much larger question. But in terms of phacotrabeculectomy or phacoglaucoma surgery, it certainly can be done, and we do it often. Where if you're going to refer to angle closure, then one of the predictive things, one of the big things is whether or not the patient's pressure is under control or not, and whether or not you think that cataract surgery alone will allow these patients to achieve what you deem to be target intraocular pressure. What can be useful is actually distinguishing appositional closure versus synechial angle closure. So that appositional closure, alone prior to cataract surgery means that most likely the angle configuration will widen and you'll get some kind of trabecular meshwork function back. Whereas often if it's been going a long time or there's synechial angle closure, that basically there might not be such a large pressure reduction, in which case you might think about doing things combined. But where possible, I mean, I personally always prefer to do things separately. But here in Perth, we've also got the benefit of having relatively gentle procedures. So I do a lot of cataract Zen surgery, for example. So phaco Zen can be useful in these cases, or phaco Presaflow, or even phaco tube. So yes, I do prefer to do things separately when I can, because as standalone surgeries, your chance of glaucoma surgery working and being maintained is higher. But one should not be afraid to do combined surgery when indicated.
Yeah, the same with me. Me too. Me too. Now, yes. Now the last one I think from Dr. Diela. Thank you very much, Dr. Jeffrey, for your excellent lecture. I have one question. Which case and when should we give atropine in block?
Look, I think I basically give atropine preoperatively for all my patients. For me, it's like a lucky charm. But certainly I want that ciliary body rotated back as possible. And in these patients with angle closure who are at higher risk of developing post-operative aqueous misdirection, I would typically put in a drop of atropine at the end of the case. So worst comes to worst, it allows me to see the fundus post-operatively, and for whatever it's worth, I'm just maintaining that AC space. So I don't know if Professor Werner or Prof. Morgan or anyone does anything different, but I do find atropine useful in my practice.
Mm.
And certainly, if I think a patient's at risk of ciliary block or aqueous misdirection, I'll put it in prophylactically or prior to surgery anyway.
Oh, I see. Okay. Will it? I mean, with the reflection after the surgery, so you will put it for sometimes, because if a patient using an atropine, the patient will feel a bit blurry, right? Especially because we make the ciliary body like a cycloplegic. It is a cycloplegic, right?
Yeah.
So
So
when
it'll rotate the ciliary body backwards, and yes, these patients will be dilated. So the effects of atropine can take up to 2 weeks to wear off.
Yeah, I know. Yeah.
But for me, that's as long as you counsel your patients and let them know that this is going to be the case and this is what to expect after surgery. It can be a while for you to be able to focus properly. But for me, it just basically offsets that or reduces that ciliary block.
Okay. Prof. Morgan, do you also did that?
Yeah, I do. I do use atropine or home atropine or a cycloplegic agent in patients with ciliary block. I probably, if they're developing ciliary block, then I'll generally just remove the lens. I don't always, I mean, I don't put them on atropine necessarily unless they've got a problem leading up to their cataract surgery. But there are some patients who can't have lens surgery or have got clear lenses and 6/5 vision that I'm trying to avoid lens surgery. And actually, some patients who have had lens surgery and are still in ciliary block, which is a rare condition, where even low-dose atropine can actually help. So yeah, I do use it sometimes. Yeah.
I usually did that give that if the patients actually have like a malignant or malignant glaucoma, I will give that.
Yeah.
So I think it will be the last question. It is very, very fruitful discussion. Thank you so much, Dr. Jeff, with the excellent presentation. We got a lot from you, and also Dr. Yura. Thank you very much for the case presentation. It is very, very nice case, and Dr. Diela also with the case, and I think also Dr. Rio helped with this case. We now end we will end our discussion. Thank you so much all for attending, and we will have photo session for the last minute prior the we'll be taking the photo, I think. Dr. Nikki or
Dr. Astrid
Oh,
will
Dr.
take
Astrid.
the photo. Yeah.
Oh, yes. Hi, Dr. Mita.
Hello. Yeah, so yeah, I hope everyone can open the video
and Dr. Astrid will start the photo session. Please, Dr. Astrid, you can count.
Okay, I will start counting now. 1, 2, 1, 2, 3. The next slide. 1, 2, 3. Okay, I think that's all.
Okay,
Thank
thank you
you.
very much.
Dr. Astrid.
Thank you very much. Thank you
Thank
very
you
much.
very much,
Get well soon, Professor Morgan.
Professor.
Get well soon, Prof. Thank you, everyone.
Thank you everyone for joining session.
Thank you, Dr. Jeff. Thank you, Dr. Firna. Thank you, Prof. Morgan.
Thank you, Dr. Jeff.
Hope to see you guys at ANSGIS.
See you. Thanks everyone. Thanks,
Yeah,
Jeff.
thank
Thanks,
you.
Yura. See you, Verna.
Thank you.